So our first speaker is speaking via video. This is Linda Lušić from Split in Croatia. And Linda's going to talk to us over video, and actually then we'll hopefully zoom in for any questions from the floor at the end. But there won't be questions. Oh, okay. Sorry. There won't be questions. So Linda's going to speak on sleep quality, excessive daytime sleepiness, and increased risk for OSA in patients with OI. Thank you.
Hello, and greetings from Split, Croatia. My name is Linda Lušić. I'm postdoctoral fellow, psychologist at the Department of Neuroscience and Split Sleep Medicine Center in the group of Professor Zoran Đogaš. I'm really sorry that we were not able to attend the meeting today, but I hope that I will be able to share the main insights of our research and maybe ideas for future studies during this talk. So we have assessed sleep quality, excessive daytime sleepiness, and increased risk for obstructive sleep apnea in patients with Osteogenesis imperfecta. I should start with a few details on obstructive sleep apnea, since I'm not sure how much the audience is maybe informed about it. It may be definitely present with or without symptoms, and the problem is that it's often accompanied by a number of comorbidities. So it's primarily characterized by cessations of breathing during sleep. However, a number of other comorbidities appear in this diagnosis and are today a huge issue. The treatment of apnea, fortunately, is considered very beneficial in minimizing the associated adverse clinical outcomes. And the problem is that this disorder overall has increasing prevalence, and the estimation is that today almost 1 billion people in the age group from 30 to 70 years actually suffer from a mild to severe obstructive sleep apnea. It very often goes unrecognized, it is underdiagnosed, it is also masked how big of a problem is it in the overall health issue, because often it's not recognized, but we know that definitely it is accompanied with this cessation of the airflow that also have been contributing to changes in so-called sleep architecture. So we should have a similar distribution of sleep stages during total sleep time. However, in these patients, we can see that there is a significant reduction of certain sleep stages, such as, for example, sleep stage 3 or delta or slow wave sleep, which then contributes to certain daytime changes in these patients. Their sleep deprivation sometimes, not always, but definitely to cognitive impairments, neurocognitive impairments in terms of slower reaction time and additional changes that are often accompanied by, for example, excessive daytime sleepiness, which is often assumed also to necessarily be included in the clinical picture. However, it does not necessarily mean that patients with obstructive sleep apnea should be sleepy during the day. We have different diagnostic categories from mild to severe, depending on the number of cessations of the airflow that actually happen during a single night of recording. So if the number is above 30, so 30 cessations of breathing during sleep or more, then we can say that these patients have severe form of apnea, and that it's definitely something that should be treated with the use of continuous positive airway pressure machine that actually is something that under pressure flows the air through the mouth or the nose or both, in order to actually stop these cessations. And it is very effective. It leads to a significant decrease in the number of apneas, but the problem is that it's something that requires adjustment, and we have problems with these patients because they have low adherence or compliance to CPAP machine. But it's something that definitely should be worked with, because it can increase, and it's a huge problem if you leave the patient with the apnea, because with time patients usually develop other comorbidities if they have not had them already, and it's most commonly diabetes and ischemic heart disease in men, whereas in women more commonly hypertension and depression. But if you look at this image overall, you can see that the number of comorbidities in obstructive sleep apnea patients is most commonly from 2 to 3 comorbidities, and very often from 4 in even more comorbidities. In osteogenesis imperfecta, maybe I don't have to talk about it a lot since you are the experts here. The symptoms that we see may have detrimental effects on quality of life and sleep quality, and these symptoms may promote development of various sleep disorders and sleep quality issues, especially when it comes to pain and fatigue. And what I've encountered in the magazine recently published is that the 5th cause of clinical symptoms experienced by patients with osteogenesis imperfecta is actually something related to sleep. So just after pain, fatigue, soft tissue problems, and scoliosis, there is sleep problems. So this is actually a sign, a warning, how important is it to assess this overall. We have stated a hypothesis through which we said that patients with osteogenesis imperfecta will have poor sleep quality, excessive daytime sleepiness, and increased risk for apnea. You can see the distribution of our patients here based on the type of osteogenesis imperfecta, and we have assessed their sleep quality with the first questionnaire, daytime sleepiness with the second one, and risk for OSA, risk for apnea, based on stop and stop back questionnaire, asking them, do they snore? Do they feel tired during the day? Has anyone observed that they stop breathing? And do they have high blood pressure? So STOP is a risk assessment for obstructive sleep apnea. We have also used the more complex form, including the bang option, stop bang, with body mass index assessment, age, neck, circumference, and gender, in order to optimize this risk assessment. You can see that we had 20 patients, of whom 11 male, and overall, if you look at their sleep quality, it's already something that has been assessed as low, because when it's above the cutoff point of 5, it's something that is indicating low sleep quality, even though excessive daytime sleepiness was not that high. And it was not something to concern about, this average value of 3 reported in these patients. We can see that most commonly the risk factor was tiredness and hypertension, and less commonly snoring, and observed to be stopping or breathing during sleep. And the overall risk was not that high when assessed with this instrument of STOP, just 4 questions, but when we included the other 4 in the stop bang questionnaire, which has higher sensitivity and specificity, we can see that the assessment of patients who have risk for apnea was 40%, which is very high. And we tried to compare these small two groups with risk for apnea and no risk. We do not see differences besides age and body mass index difference, but we expect, if we increase these groups, that we could see differences in sleep quality, in excessive daytime sleepiness, and definitely is something that triggers us to assess sleep disorders, especially apnea, in this group of patients. But not just apnea, and overall sleep quality, which is low here, is something that's indicating that we have to do something about it, because it's not something that we are doomed for. If we have low sleep quality, this is something that we can really change, and we have to share maybe the knowledge, psychoeducate these people, give them good insights on sleep hygiene in order to improve their overall sleep quality. So in the end, I hope to continue this research. We plan some case control studies, possibly even interventional studies with these patients. And I send you greetings from Split, Croatia, and I hope that if someone has any question, or I don't know, you want to share some feedback, you will feel free to contact me. Thank you again.